Guys. This is Dr. Anil Bajnath, and thank you so much for joining us today to discuss this topic I'm excited to share with you on the principles and practice of precision medicine as it's applied to this idea of scientific wellness. I hope everybody's staying safe, and thank you for your time during this interesting period of time in our lives and training. And joining us today, taking the time to join us today. So just a little bit about myself. I am board certified in family medicine, integrative medicine, functional and anti-aging regenerative medicine. I also am the founder of the Institute for Human Optimization, Precision Medical Research Group, and a medical consultant for the Cellular Biology Research Institute and the Chief Medical Advisor for Clear Health Now. Just want to make sure that all my commercial interests were kind of related to you guys there. And so for today, we're going to have a discussion about the new paradigm of medicine, moving from this idea of evidence-based, disease-oriented medicine towards this evidence-based systems biology, precision medicine, and the principles behind that govern scientific wellness. We're also going to look at the 4 Ps of precision functional medicine, which include predictive, preventative, personalized, and participatory medicine. And then at the end of the discussion, after taking a deep dive into different components, we're going to look at this idea of data-driven, personalized health plan and how to build your own personal health plan. And then in the end, we'll take this some questions and have a discussion about the future. So starting off, looking at our current model of healthcare as it stands today, we have what we call evidence-based medicine based on these standardized guidelines. And that's translated into this clinical reality, and how it's applied today is very unique. But how we got here is even more interesting. I'd like to take a second to just explore the history of healthcare and health education in this country and how we got to this place of evidence-based practice today. This actually starts back with the Flexner Report of 1910. This Flexner Report in 1910 really transformed how we perform and practice medicine today and set forth the first scientific basis of biomedical sciences that's been adapted to our health educational system in America. And at the time in 1910, and at the time of the production of the Flexner Report, there were 165 medical schools in America. And what the report proposed was the establishment of this new biomedical model, which was actually adapted from the Germans in regards to standardizing how medical training is taught and executed in this country. 15 years after the Flexner Report, we essentially cut down medical school programs, standardized the education, and then we were left with 37 medical schools. With that, where we're at today is this idea of evidence-based medicine, but it's usually centered around a disease-centric, population-based level of thinking. What do I mean by that? As you're going through your education right now, most of you guys are medical students or and doing a fellowship in integrative medicine. We're looking at this idea of, well, we have an individual that comes to our office and they have this, their clinical presentation. They might have an A1C of greater than 6.4, and that just bought themselves some metformin. They might also have a dyslipidemia and an elevated cholesterol level greater than 200, and we're going to throw on a statin drug. And they also have high blood pressure. And now we have, we're going to try to stratify that individual and give them a medicine that's going to be beneficial for their diabetes, dyslipidemia, and for their hypertension. So we might give them lisinopril. That's kind of the standard of care for which we're practicing right now. But I'm going to make an argument that instead of looking at individuals in regards to this disease-centric model, that we'll move forward and look at them more on an individual basis. And I'm also going to make the argument that the way we're practicing medicine is very imprecise. And by that, I mean, looking at this article from 2010 Nature, This article actually looks at the most common medications prescribed in the US right now, the top 10 highest grossing drugs in the US, and how the clinical response that we're getting. So this article actually looked at what is known as the number needed to treat. It's a biostatistical uh, measurement that we use. It's actually epidemiological measurement that's used in communicating the effectiveness of healthcare interventions, typically with a treatment with a medication. Now, this number needed to treat is the average number of patients who need to be treated to prevent one additional bad outcome. So sometimes when we're looking at it in the context of population-based medicine, every day millions of people are taking medications that won't help them. The top 10 highest grossing drugs in the United States, between 1 in 25 and 1 in 4 people who take them. From like even drugs like statins, which is so commonly prescribed and routinely used to lower cholesterol, there's benefit as low as 1 in 50. So that's a really important concept to take into consideration in terms of our prescribing practices. And there are even some drugs that are very, very detrimental to specific ethnic groups because those people weren't represented in some of the clinical trials that we use to set forth our prescribing practice. So moving forward, I think looking at this new idea, it's not even new, it's actually was kind of brought into light by the Obama administration when they invested a significant amount of money into the Precision Medicine Initiative. And since then, we're taking this one size fit all model to prescribing and practicing medicine, where we kind of don't know what kind of clinical outcomes we're going to achieve based upon the individual response. And we're further stratifying individuals on top of the original measurements of, looking at their disease subtypes, risk profile, demographics, socioeconomic status, biomarkers, and we're going to further compound that with some individual patient levels of individuality in regards to looking at genomics and omics as a whole, and I'll get into that a little bit later. Lifestyle, patient preferences, history, compliance, and all these other factors, and we're going to try to actually make medicine more individualized for the patient. Now, there's a lot of research and evidence going in towards this in regards to clinical applications for cancer therapy, orphan drugs for these unique genetic anomalies, and so forth. But this is a trend and the new paradigm shift from transitioning from a one-size-fits-all to a precision medicine model with multiple levels of patient integrations. So overall, the healthcare systems around the world are increasingly demanding precision medicine healthcare solutions, and these solutions will provide improved quality of care while demonstrating cost effectiveness and comparative effectiveness to the standard of care. And with that, we're looking to move from this trial and error based way of practicing to more evidence based and having these more targeted populations. And in doing so, one of the things that we need to look at is the advancements we've had in DNA sequencing technologies and commercial availability. In 2004, you could see the cost of sequencing the human genome went from close to $29 million to $1,500 in 2015. And nowadays, you could actually find DNA sequencing, complete genome sequencing for around $500, and there's a few labs that are doing that commercially. So needless to say, Moore's Law has definitely taken effect in regards to accessibility of this information, and how we could apply it clinically is what I'm hoping to present today. So one of the ideas is taking this, using the information historically of this biomedical model, population-based evidence, and applying it to N of 1 medicine. I'll get into that a little bit further, but essentially the medicine for the average should now be further stratified to the medicine for the individual. And what N of 1 medicine refers to is essentially, and this is, I'm quoting a clinical from the Argument for a Clinical Trial by Eric Topol and his group of Scripps, is N of 1 is essentially single subject clinical trials that consider the individual patient as a sole unit of observation in a study, investigating the efficacy or side effect profiles of different interventions. The ultimate goal of an N of one trial is to determine the optimal or best intervention for an individual patient using objective data criteria. Coupling that with an idea of scientific wellness and human optimization will, I think, transcend how we're approaching healthcare. And moving forward, I think once, it's interesting because we're kind of launched out of the birth canal at birth without a blueprint or instruction manual on how to thrive in a complex world. And we kind of exist in this preclinical state where, we're quote unquote disease free, but we might be exhibiting some preclinical syndromes. We might have some anthropometric data or biomarker data that might be high or low, which could be the preceding events needed to make a clinical diagnosis later on in life. And during this time period, we might be exhibiting varying levels of epigenetic modifications prior to making the exact clinical diagnosis of a disease. And then once we make that clinical diagnosis, we could go in either direction in terms of disease regression and curing the disease or chronic disease management. And this is important to look at in the context of lifespan and this idea of health span. I think it's important to keep in mind aging in a graceful manner and looking at individuals to hopefully grow old into what Eric Topol calls the welderly, growing old and aging gracefully without disease and cultivating some level of a health span. But more specifically, I think looking at the root causes of what's mediating this disease pathophenotype and the disease progression. And often I like to look at this model. This is very common. It's been adapted at multiple levels, but looking at this health trajectory and how we get to this place of disease and imbalance. And typically, clinically, when we get patients, unfortunately, they've been dealing with chronic issues that have been mediating their disease process. And in functional medicine, we call these ATMs, antecedents, triggers, and mediators. And these ATMs influence this pathophysiological process for which ultimately we are left with some sort of imbalance and or disease process in the end. But at the end of all this is looking at this chronic inflammatory process, poor nutrition and micronutrient deficiencies, looking at the environment and environmental toxicities and how we perceive ourselves and we have our relationships. These are the true ATMs that influence our pathophenome and how we get to this imbalance of disease. So although we often treat diseases separately, most human diseases are not independent of each other. And oftentimes we're actually looking at diseases in individual silos. So if you have issues, you're seeing cardiologists, endocrine issues, endocrinologists, nephrologists for your renal issues, and so forth. But oftentimes these diseases aren't coming about based upon a single breakdown in a system, but a dysregulation or imbalance within the entire system and network. And this is where I think we should be shifting our attention towards systems biology and looking at things in regards to deep molecular complex networks of omics. And omics refers to the comprehensive study of human systems biology, and looking and connecting these molecular dots is and incorporating omics into medicine has created a network of knowledge illuminating our comprehension of molecular patterns and disease processes. And this stems from various levels of organization, starting with the gene, the cell, the tissue, the organ, and making its way up to the social interactions that we have with individual. And this complex network, when applied to pathophenotype, has some pretty significant implications on how we could approach individuals using this lens of individualized healthcare. So taking a step forward, I think when we look at precision medicine, and I would like to, definitely give credit to Dr. Leroy Hood and his advancements with the Institute for Systems Biology and his work with Caltech. He actually coined this term P4 medicine. And P4 medicine relates to what I think is going to be at the heart of precision medicine and its clinical applications in regards to being predictive, preventative, personalized, and participatory. And this is a very important concept because, no longer are we going to just do this trial and error approach. We could leverage the information that we have at our access, and that is using genomics and advanced biomarker testing for risk stratification and empowerment, personalizing medicine to their genetic blueprint and their biomarker analysis, and working towards prevention to make actual formative changes so that we could actually help mitigate the disease process. And a big part of this is participation. Patients need to be actively engaged and participating in their own health regimens and taking account or responsibility for their self-preservation. So this is, leading to what is the beginning of, I think, a paradigm shift in the medical landscape. Our contemporary model right now is very reactive, population-based, averaged medicine that's applied generally speaking. It's very disease-centric, and the interventions are centered around treating and managing disease chronicity, not curing. Whereas health optimization medicine is very proactive, individualized, wellness-centric, research-oriented based on this N of 1 approach, and interventions are centered around primordial prevention, healing, and curing disease. Moving forward, the process of scientific wellness is very interesting. And I would like to pause here for a second and make reference to a landmark clinical trial that was published in Nature Biotechnology in 2017. It was the actual study of wellness. The name of the study was a wellness study of 108 individuals using personal dense dynamic data clouds. And this was published by Nathan Price and Leroy Hood. And what they did was over a 9-month period of time, they looked at these 4 different quadrants that was used to help determine individuality and apply it to this idea of scientific wellness. They looked at genomics, genome sequencing, and GWAS studies, and then they applied it to biomarker analysis, looking at several, hundreds in different metrics. They also looked at microbiome analysis and shifts in the microbiome with their treatment plan over time. And they also were provided with different tools and resources for lifestyle monitoring and self-tracking. And over that period of time, long story short, it's a great article to look at and gets into a lot of details of their conclusions. They were able to scientifically, objectively demonstrate a regression in biomarkers of aging and disease process using the of scientific wellness, and it's what I think primary care in this country should start looking at and adopting to our clinical process of treating and managing disease and promoting wellness. So starting off with this, I'm going to take a little deep dive with looking at genomics and how it's applied to our current clinical model. And it's very important to look at in regards to, where we started, where we are today. Hippocrates, during his time, had the 4. I'm sure you guys heard about this in terms of yellow bile, black bile, phlegm, and blood. Today, we have the 4 nucleotides that make up our DNA blueprint. And this DNA blueprint allows us to identify possible disease risks, prevent disease, use this information for empowerment, improve diagnosis, and develop more targeted treatment plans for individuals. So I don't want to get into the complexity of genetics or anything, but it's important to know that essentially that those 4 nucleotides basically go on and form different genes. And there's several different genes that influence and code for proteins. So they're literally the instruction of proteins. And as genes code for proteins, they influence our structure and overall function. Moving forward, I think there's going to be a clear distinction that needs to be made clinically, the difference between looking at genetics versus genomics. Genetics often refers to this idea of inborn errors of metabolism, usually associated with single genes and congenital disorders such as cystic fibrosis, like PKU, muscular dystrophy. This idea of inborn errors of metabolism was actually originally coined by Sir Archibald Garrod in 1908, where he looked at these inborn errors of metabolism and determined that there were genetically determined disorders caused by abnormalities in the quality and structure of these specific enzymes and proteins. And this is inherently different than the idea of, similar but different, the idea of looking at genomics as a whole, where we're looking at different genes, their functions and interactions with each other and the environment. And this looks at something called single nucleotide polymorphisms, which we'll get into in a second, epigenetics, epistatic relationships, and how it could be applied in terms of individualizing medicine in the fields of pharmacogenomics and nutrigenomics. Moving forward, SNPs refer to a variation of, so single nucleotide polymorphisms is actually what makes us unique and individual, and what we leverage and use in clinical application to identify these variations in single positions of DNA sequencing amongst individuals. When there is more than 1% of the population that does not carry the same SNP in a specific DNA sequence, these variations can make the designation of becoming a SNP and influence many different individual features. So as you can see here, the normal gene without the SNP has a normal enzyme and substrate binding capacity, whereas the single nucleotide polymorphism has an altered protein shape which affects the function of the protein or enzyme or substrate. Consequences of these genetic polymorphisms may result in amino acids coding for a stop codon and could affect the conformational proteomic structure. It can result in change in protein function, quality and quantity, or sometimes it just has no effect. So moving forward, so if there's no SNP, we have normal protein and enzyme function and allows for the appropriate biochemical processes to take place. And then looking at this illustration here, if there is a single copy of a polymorphism, you could see that one gene could code for protein and the other one is going to code for a protein that won't effectively function. And you could have a decrease in overall enzyme kinetics or whatever it may be, but still have some level of preserved function. Now, if both proteins have a polymorphism, it could result in a completely altered shape or instability of the enzyme or protein that's being coded for, and may or may not always have some detrimental outcomes. So again, this idea of genetics and genomics and how it affects us in clinical applications is very important. For us as clinicians, looking at it in the context of, like I was mentioning before, pharmacogenomics and nutrigenomics is very important. And what we have, and I think is going to be important for the overall process of scientific wellness. And pharmacogenomics is essentially just looking at how genes affects a person's response to drug therapy. It combines pharmacology and genetics, and we look at these different variations an individual will clinically respond to medicine. And these genetic polymorphisms in drug metabolizing enzymes could also affect transporters, receptors, and other drug targets, and have been linked to their individual differences in efficacy and toxicity. Very important in looking at that in the context of, giving the right drug for the right patient at the right time at the right dose. And this is one of the arguments of pharmacogenomics. Now, nutrigenomics and nutrigenetics, very fascinating idea. There's a quote that one of my mentors, Jeffrey Bland, speaks about, and that is, food is information. Food is communicating with your DNA. Food has these phytonutrients that actually bind to cell surface receptor, G protein coupled receptors, and actually influence our gene expression. Oftentimes, it could be in our favor if we're eating the right foods, and sometimes it could be very detrimental. But either way, the nutrition we consume is influencing our genetic expression. Moving forward, looking at the idea of epistasis and epigenetic relationships. Epistasis refers to how there's gene-gene interactions and how the protein of one gene or the actual gene expression affects the ability of another gene expression to function as well. So that's a very complex level of science and medicine. I like to focus more on epigenetics, which is actually looking at the interaction between our genes and our environment. And this is actually a very exciting area of science and research moving forward. Here we can see that it's actually now making its way into conventional literature with a fascinating article I recommend everybody reading from Dr. Feinberg at Hopkins University published this article in New England Journal of Medicine in April of 2018, looking at the key role of epigenetics and how that relates to disease prevention and mitigation. So this idea of epigenetics is actually, it's not a mutation in our gene expression. It's actually not changing or altering our DNA sequence, but it's actually turning up and down volume control of very specific genes. And it does so in a few different through a few different mechanisms, including what's called HDAC proteins, which are histone deacetylase, methylation patterns, phosphorylation, and ubiquitination. So I'd like to say that, and if you want to take it even further, we could look at how we've now moved into a time period where we could measure these epigenetic changes and our unique epigenetic. And that gets into the work of the epigenetic clock and Horvitz and this whole area of aging that's super fascinating. But what I want to emphasize with this is that we have the ability to turn up and down the volume control of favorable gene expression so that we could enhance our resilience and age gracefully. So I'll leave it at that. So overall, looking at genes and everything else, there's so many different clinical applications. But one thing to keep in mind is that your genes aren't necessarily your destiny. They actually say that it averages 20 to 30% in our overall pathophenotypical process. But we could leverage this information of genomics and genetics in regards to risk stratifying individuals for cancer, looking at BRCA1, BRCA2, cardiometabolic issues, neurocognitive degeneration, and Alzheimer's, and looking at ApoE4, and all sorts of fun stuff. Looking at pharmacogenomics, this is, I think, we could leverage this information more readily in our day-to-day practice, and looking at specifically, whether somebody's ultra rapid, extensive, intermediate, or a poor metabolizer, and how that affects drug toxicity and clinical response. Another big one is looking at SLOCO1B1 and its role in statin intolerance and its risk for myopathies. And again, we have these clinical or this nutrigenomic potential of applying genetics to clinical practice, where we're looking at these individual polymorphisms and how they affect health. Also, this idea of our unique genetic blueprint and its influence on how it affects our overall response to the environment from food intolerances. We know that there's a HLA-DQ phenotype or genotype that is associated with celiac disease. But also one of the things that I like to bring attention to is the medical director for integrative medicine here at GW, Dr. Andy Heyman, and his work looking at the SIRS pathway. Him and Dr. Shoemaker have coined this term, the dreaded genotype, haplotype, which is associated with this predisposition and hyperresponsiveness to these biotoxins. So again, knowing this information, a whole broad range of clinical applications that could be used to further identify who we're sitting with and how their blueprint influences our direction in clinical management. So transitioning now from genetics to the to biomarkers, I think the next phase of personalized medicine is looking at this idea of biomarkers. Well, biomarkers are very important. They say that genetics, but biomarkers provide the evidence. Using different biomarker analysis, you're able to establish a baseline of your health status. You could use it to investigate the underlying cause of disease and leverage this information to, again, focus on optimizing health and performance. And typically, biomarkers refer to a measurable substance in organisms and it's typically measured through blood, urine, and saliva and tissue, and are indicative of some sort of phenomenon such as disease, infection, or some sort of environmental exposure. And the way we look at biomarkers is typically in the context of a bell curve distribution and whether or not we're falling into what quote unquote normal. And I'll expand upon that in a second. But biomarkers clinically have various applications, and there's so many different ways of looking. I think comprehensively right now, looking at advanced lipid profiles, I have additional studies in lipidology, and the NLA, National Lipid Association's making an argument that we really need to start focusing on LP(a), not just LDL or oxidized LDL. We look at these diabetic markers and A1C, different hormones, and some basic markers. But I would like to make the argument we should expand upon the typical markers that we look at and start looking at it in the context of wellness, and also identifying other markers that could be mediating the disease processes, including heavy metals, micronutrient deficiencies, and looking at this omega-3 to 6 index. And again, looking at biomarkers in the context of being predictive and proactive and utilizing this for personalized care is very important. Conventionally, we look at biomarkers strictly in the context of pathological ranges. Typical reference ranges provide laboratory testing results and are reported in this wide distribution. And if you're too high, it's pathological. Too low, it's pathological. But we're not looking at things in regards to a functional perspective. And this is where functional medicine comes into play, and identifying these various biomarkers and how they could be leveraged to promote wellness and curate health. Biomarker analysis in conventional context looks at, again, you're disease-free to a certain point, and then all of a sudden, your A1C goes above 6.4, you're diabetic. Well, before you get there, we have signs of prediabetes, once you get above 5.5, and we're now starting to trend in that direction of dysfunction. And this is opportune time where we could actually really have aggressive personalized lifestyle medicine that could be used to potentially augment that process. So just going a little bit further, looking at biomarkers and how this could be leveraged for functional wellness. This is just a brief list of certain biomarkers with identified optimal ranges. However, there are caveats to this. One of the caveats is looking at, hemoglobin A1C. There was the 2008 Accord trial that looked at aggressive pharmacological management in type 2 diabetics, where they drive their A1C pharmacologically less than 6, actually had increased morbidity and mortality. So the idea is not to go crazy pharmacologically, but try to naturally do diet, lifestyle, and patterns of behavior that's going to help optimize health and naturally decrease these levels. The biomarker homocysteine is actually a surrogate marker of MTHFR gene polymorphism, defective methylation patterns. And when you see this elevated, that's an indication that you're not methylating properly. And some people like to, different clinicians have different goals with it from 7 to 13, but ideally seeing that marker lower is better. Now, looking at vitamin D, and I can personally attest to this, I have what's called a VDR polymorphism, vitamin D receptor site polymorphism, and I actually need higher amounts of vitamin D to stay elevated. And there's different research out there looking at vitamin D in the context of osteoporosis, osteopenia, and what the target range should be. And typically, lab ranges report vitamin D from 30 to 100, big range. What's optimal? A lot of clinicians in the functional medicine realm like to shoot for greater than 50 to 80. Another, I mentioned before, the omega-3 to 6 index is actually a marker for cardiovascular health. You could order it through LabQuest or I'm sorry, LabCorp and Quest Diagnostics, and it tells you this ratio of another level of lipid dynamics beyond cholesterol. There's another biomarker that is incredible in regards to looking at toxicity levels. It's beta-hydroxy-D-guanine. And this biomarker is actually indicative of of genotoxicity, not cytotoxicity, but genotoxicity. It's very important to look at. So needless to say, there are different ways of leveraging biomarkers and how we could apply this information towards measuring and objectively obtaining a level of scientific wellness using the appropriate interventions. So moving forward, we're going to shift the dynamics now, looking at the dynamic microbiome. This is such a fascinating area of study, and honestly, a whole course on the microbiome and the information that we have so far with the human microbiome trial with the NIH. But long story short, I'm going to keep this very superficial and broad, but leveraging the microbiome is very critical at looking at how disease, how the microbiome influences our health and disease. Hippocrates said that all disease begins in the gut. Well, that's a very important concept. What does that look like? Well, starting off with a eubiosis or a normal healthy gut environment, we could see that there is this regulation of good bacteria, secretory IgA and mucus, healthy epithelial cell barrier, and tight junctions, and normal immunological programming. However, when there are different insults to the gut, it could lead to what's known as dysbiosis, lead to an imbalance, lead to increased gut permeability, and shift some of the immunological dynamics. There is a gut-brain axis, a gut immune axis, a gut endocrine axis. Our microbiome influences everything. So one of the ways that we could view this through the lens of science is looking at these different biomarkers associated with bacterial and fungal dysbiosis. I'm not going to get into this too much. There are entire courses on this, but long story short, there are labs out there for example, like Genova Laboratories, DSL Labs, and Doctors Data that look at measuring these different dysbiotic markers and provide clues and indications to the clinician that there's a dysbiotic gut. But big picture moving forward, I'd like to look at this slide here. This was adapted from Dr. Alicio from Harvard. In his research with looking at increased gut permeability, dysbiosis, and how this loss of mucosal immunohemostasis leads to essentially autoimmune disease. Starting off with our bullet point number 1 here, normal physiology regulates the permeability of transcellular absorption into our bloodstream, right? But with time, there's a potential breakdown in these zonulin and zona-occludin proteins, and it to be associated with a breakdown in the mucin production, dysbiosis, and this allows for macromolecules to seed into the bloodstream. These macromolecules could be undigested proteins instead of peptides or amino acids, and they could circulate into our immune system and trigger this pro-inflammatory cytokinetic vicious cycle, which could ultimately lead to an imbalance in the immune system and lead to disease. Fascinating research, highly recommend looking into it. But it's something that we, as clinicians, we really need to focus on is promoting gut health, generally speaking. And this could be viewed on so many different levels. There's another idea of, not even idea, in the literature called postprandial metabolic endotoxemia. Postprandial metabolic endotoxemia is associated with, after you eat, you're actually shedding this lipid A into circulation, driving a lot of these pro-inflammatory mediators that are actually leading to just a dysregulated immune system. And we could leave it at that. And there's incredible evidence to show that this is actually associated with most of our inflammatory disease processes, including diabetes, heart disease, and so forth. I mean, super fascinating work, and components of scientific wellness that we really need to pay closer attention to when we're sitting down with patients. And a clinical caveat and pearl to this is the functional medicine approach to this. Generally speaking, how do we approach this with individuals? Well, in functional medicine, we have this 5R program to healing again, which looks at removing these antigenic foods through elimination diet and replacing these poor nutritional items with nutrient-rich and nourishing foods, re-inoculating and restoring healthy eubiosis or balance of gut bacteria while repairing the intestinal lining. And during this process, we're hopefully rebalancing the healthy gut terrain so that we could have normal function from there on. I added on the 6R, which is a reflection. I think this reflective process is very important to have with patients so that they can actually go through the other R's so that they can identify how they got to this place of imbalance to begin with. And it oftentimes starts with the foods and the information that we have. Moving forward, we're going to look at just the last, I think, component to scientific wellness, which is biometric analysis. And this is really exciting. Hippocrates said, let's do it for the gram. Okay, he didn't say that. There was no Instagram back there. But leveraging information that in these different mobile health technologies is incredibly powerful at empowering patients to become more proactive in participating in their own health. And these different technologies could enhance communication with the clinicians and track their own metrics over time. And there's just so many varying clinical applications that's growing in the literature if you were to look up mobile health technologies. And Dr. Eric Topol speaks about it in his book, The Creative Destruction of Medicine, and how we're using this information to help further enhance our empowerment of our own health. And again, looking at these wearable smart technologies, we have all sorts of headbands that can measure EEG levels. There are watches that are measuring your heart rate, 1 lead EKGs in the new Apple Watch. I'm actually wearing an Oura Ring, which actually is measuring my heart rate variability and stress levels and measuring my sleep. And there's just so many different pieces and tools and technologies that are becoming available to us here now that we could actually start quantifying our health and realizing this breakdown in our routine and behaviors that could be mediating the disease process. And I could do a whole talk on this alone, but these are some of the things that we could use to help leverage and monitor our patterns of behavior and be able to objectively identify stress levels, mood and behavior, looking at our BMI, body fat composition through scales and technologies that sync with your provider, home blood pressure monitoring, very critical. I know I suffer from white coat hypertension, and most people do. And it's something to really look at, in terms of doing more precise medicine. Sleep quality, I think, is pivotal, and I'm very my looking at how sleep is my sleep quality and what affects my sleep quality. Now we have these continuous glucose monitors and implantable devices where we're able to get a real-time clinical feedback on the foods that we're eating and how it's affecting our blood sugar. And there was actually a fascinating article that came out, I think, 2 or 3 years ago that looked at the biggest determining factor for your body's individual glycemic response is the microbiome. So it's hard to predict who's going to respond with their glycemic response to, the food that they're eating because it's so individualized. So there's a lot of research and development that's going to be needed moving forward to further quantify how we could use this information. I think it's a very exciting time in healthcare and medicine as a whole for scientific wellness. And moving forward, this kind of concludes this idea of scientific wellness using, I think, these pillars of genomics, biomarkers, microbiome, and biometrics to empower the patient to achieve this higher level of quality of care. And this is actually a little blueprint that I put together here so that you could start empowering yourself to build your own data-driven health regimen. I think it's to, just look at the big picture. And with direct-to-consumer analysis, we have access to all sorts of resources so we could be more proactive with our healthcare. And this starts with, I think, organizing your personal health inventory. Do a good health inventory, including a family history, social history, and so forth, and lay it all out so that you could eventually, or look at and exclude any diagnosable underlying conditions, hypertension, stress, anxiety, whatever it might be, and then determine your health issues and how you want to fix and optimize it. And then it's going to be, I think, really important to perform a symptomatic survey. Clinically, we use a symptomatic survey to establish a baseline and track the improvement of symptoms with time and see a reduction, hopefully, in your symptoms as you implement these different changes. And it's going to be a very important component to all this is performing an audit of your diet and environment, eliminating potential stressors. And then taking a deep dive into your DNA blueprint, I think has some utility. Looking at if you're a slow caffeine metabolizer, looking at if your COM affect neurotransmitter imbalances associated with a COMT polymorphism, looking at DNA and using this information to further understand what's going on with you, yourself, and correlating it to your phenotype. Microbiome and biometrics, as we discussed, could be all part of this equation for scientific wellness and data-driven health. And then after we get this baseline, I think it's going to be important to implement your gene lab-based recommendations, hopefully under the guidance of a trained healthcare provider, and identify and test and measure these changes over time and reassess labs as we move forward. So this is kind of like a generalized, it's almost like an outline to what these biohackers are using out there to take control of their own health and move forward with hacking their biology to promote longevity. And in closing, I think we're at a very exciting time in healthcare where we have access to all this information, and we could synthesize all this information and use it to help empower us to make informed decisions. And moving forward, I hope that you guys were able to gain something out of this lecture and some of this information. I look forward to hopefully speaking to you all and the future of medicine and what's in store in regards to precision medicine and bioinformatics and how we're going to leverage it to empower ourselves to create wellness as a society as a whole and not just chronic disease management. So in closing, I thank you all for your time, attention, and patience. And this is my contact information. Please feel free to reach out. And at this time, I'll open up the floor to discuss any questions or concerns during the presentation. Thank you.